Okay, thank you very much for joining in, all the delegates. I welcome you to the inaugural session of Trauma 2020 virtual. This year, we could not hold the conference in person because of the tough times of COVID. Nonetheless, the Indian Society for Trauma and Acute Care decided that it would carry on with its annual conference, the 10th annual conference of the Indian Society for Trauma and Acute Care. Ladies and gentlemen, you're all welcome to the inaugural session. I'm really honored and pleased to announce that our dignitaries are here on the dais. Um, we have our chief guest, Professor Vinod Paul, who is the member of the Niti Aayog, as the chief guest. We also have guest of honor, Dr. Sunil Kumar, the Director General of Health Services, Government of India. We have Dr. Vinod Jain, Professor of Surgery at the King George's Medical University, who is also our keynote speaker today. We have with us the President of the Indian Society for Trauma and Acute Care, Professor M.C. Mishra, the Vice President, Professor Subodh Kumar, the Scientific Chair of Trauma 2020, Professor Sushma Sagar, and our Treasurer, Professor Manish Singhal. Without wasting any time, we would actually like to begin our inaugural ceremony in a very traditional way by paying obeisance to the goddess of knowledge, that is Saraswati. I'll start the Saraswati Vandana.
We can't hear.
Thank you very much. And with that auspicious beginning to the ceremony, I would not waste time and call
Dr.
upon
Amit,
the founder president of ISTAC, Professor Mahesh Mishra,
The
to
audio
welcome
was
the
lost
delegates
on
as
the
well as the.
Saraswati Vandana, so don't worry. We read
Dr. Amit,
in the Saraswati Vandana ethos. Let's go with the ethos of Saraswati Vandana.
we couldn't
I'm
see
really
the
sorry.
image, but we did not see we
Yeah,
did
that's
not
right.
have the audio. Right. Okay.
Audio wasn't there, so that's
Oh,
okay.
Okay.
Thank you, Dr. Amit. I think let's move because Professor Paul has urgent meeting soon after this, so we'll not hold up. So welcome, Professor Vinod Paul, our distinguished member Health Niti Aayog. Thank you so much for giving time for this inaugural conference. It means a lot to us. Dr. Amit Gupta, Professor Amit Gupta, Professor Subodh Kumar, Professor Sushma Sagar, the architect of this Trauma Virtual 2020, along with the team, Trauma Center team, and all faculty members and residents who have worked hard for this organization of this conference. As we all know, when we started COVID pandemic in India in March, at least for 2 to 3 months, the trauma dipped. The trauma receiving in most hospitals across the globe dipped. And that was the positive side of this pandemic. There are few positive sides of this pandemic. One of them was the number of cases came down, trauma patients came down. But as the unlocking happened, we went to the uh, basically pandemic stage. And that has been happening. And a lot of hospitals have been converted into COVID care hospitals. including the AIIMS Trauma Center, which is right now functioning as a COVID hospital. Even Cancer Hospital in Jhajjar is being used as a COVID hospital. So the pandemic had taken a huge toll on training, on education, on patient care of non-COVID patients. So that has been across board all over India and all over the globe, basically. And we have had these difficult times, and that was the reason to hold this meeting virtually, as many meetings now being held virtually. Uh, Only thing I would say that in times to come, I would like to see the uh, new entity, which is National Medical Commission, giving teeth to skill-based life support training mandatory for all physicians, cross specialties, right from internship onwards, which has not happened as yet. Although competency-based curriculum has been in place under the leadership of Professor Vinod Paul. And also in India across board, we have not made CME credits mandatory for our doctors, surgeons, physicians, and everyone. Some medical councils have taken it up, like the Maharashtra Medical Council, but not all of them have done that. The other thing which I discussed with the trauma center faculty some time ago when I visited Udhampur Military Hospital, that from your MCH program, if these MCH students can go for secondment or an elective posting to military hospital in these areas for 3 months to, I think 3 months would be enough for exposure into basically military trauma, what they receive. Because in Delhi or in other metropolitan cities, that exposure is not there. So that is something I think all of you can take it up. Right now, Professor Sunil Kumar is the helm of Director General of Health Services. So you can take his help and get this training moving in coming times. This conference, naturally, we are having almost 600 plus registrations, 112, 15 national and international faculty participating in this meeting. We got overwhelming response by receiving almost 150 abstracts and oral presentations, award paper session, and also posters are on display through the virtual methods. So I congratulate the team led by Professor Amit, Subodh, Sushma, and all others for organizing this meeting. And thank you so much again, Professor Vinod Paul, for giving your valuable time. I know how you are working 24/7, and time is essence for you for rolling out so many things concerning COVID-19. Thank you so much once again.
Thank you so much, sir, for those kind words of encouragement. You've always been behind the organizing team of the trauma conferences in India. I have the privilege now of reading out the ISTAC annual report. Obviously, because this is an abridged ceremony, I will not go into details, but I'll definitely like to appraise all the delegates who are present here and the dignitaries about what we've been doing over the past year. Well, as you know, it has been a tough year for all of us because of the pandemic. I wish everybody is safe and is doing well. But we had a very successful conference in Lucknow last year in 2019 under the able leadership of Professor Vinod Jain, who's here as a keynote speaker here, and Dr. Sandeep Tiwari, who's the head of the Department of Trauma Surgery at KGMU. We had planned actually a physical conference at AIIMS Rishikesh this time. Unfortunately, because of the pandemic, we couldn't do that, and therefore the society decided that the society would take over the conference and it would do it virtually this year. And thanks all the dignitaries and the delegates for having made this conference a success. We had in January sort of a consensus meeting of about 30 specialists of trauma and surgery, and we formulated the first ever guidelines, Indian guidelines for management of solid organ injuries in January 2020. The guidelines are almost ready. We were actually about to publish it before this conference, but unfortunately, because of the COVID reasons, it could not go into publication. But very soon, the first ever Indian guidelines on management of solid organ injuries would be published. Between May and July, we also did not sit down. We continued our endeavor for educational activities in trauma care. We had a webinar on trauma in COVID times. Thereafter, we also had a detailed webinar on postgraduate teaching in trauma care in India. Thereafter, along with the Indian Association for Trauma and Critical Care, which is an offshoot of the Association of Surgeons of India, we had two webinars, one each on thoracic injury and abdominal injuries. Just to inform you that even in these pressing COVID times, 4 of our centers, national centers, have started the ATLS teaching: the AIIMS Rishikesh, Command Hospital Bangalore, Manipal Hospital Bangalore, Pune, and also KGMU. So we have got 5 centers which have started the ATLS training. I think I would briefly end there, and I would request Professor Subodh Kumar, who is also the Vice President of ISTAC, to actually present the theme of the conference this year.
Thank you very much, Dr. Amit. And this is the best platform to discuss the theme of the conference, because we have 2 policy makers in this on the dais in this inaugural ceremony: Professor V.K. Paul, the member of Niti Aayog, and Professor Sunil Kumar, who is the Director General of Health Services. And if we can give some insight so that we can see that this specialty, which is a new specialty, will come up in a big way. So what is the status of postgraduate training in trauma and acute care surgery in India? So I bring greetings from the Apex Trauma Center of AIIMS. So the government has recognized that injury is a major public health problem. And there are efforts going on to establish trauma centers in the country along the highways. Under the Prime Minister Suraksha Yojana, the medical colleges are being upgraded to have trauma care centers. All new AIIMS are coming up with trauma centers. So there is an urgent need to have an acute care surgeon, or we can call it as a trauma or emergency surgeons. But unfortunately, there is a gap between the demand and supply. So we need to have a specialty like acute care surgery. It's an evolving specialty with 3 essential components, which includes trauma, critical care, and emergency surgeries involving the non-traumatic surgical emergencies. So who is an acute care surgeon or trauma surgeon who can handle all surgical emergencies, both traumatic and non-traumatic surgical emergencies, right from the resuscitation in the ED, definitive care, and rehabilitation of the patients, disaster management, trauma prevention, training, and involved in the quality improvement programs. What is the current status in India? We have MCH program in trauma surgery and critical care, the Fellowship of National Board in the Trauma and Acute Care Surgery, and Master of Surgery in Traumatology and Surgery. In the Division of Trauma Surgery and Critical Care at AIIMS Apex Trauma Center, we started the MCH program, and Professor Mishra was the force behind it. He was the director, the then director of AIIMS, and it was started in January 2016. And now the 4 other AIIMS, including Delhi, AIIMS, Rishikesh, Jodhpur, and Patna, have also started the MCH program. I will not go into the detail of this program. It's a 3 years super specialty program. There is a fellowship of National Board. Earlier it was used to known as trauma care. Now recently it has been, nomenclature has been changed to trauma and acute care surgery to include both traumatic and non-traumatic surgical emergencies. It's a post-PG fellowship. The MS in traumatology and surgery. It was notified by the erstwhile MCI in 2010. The curriculum was developed in 2016. I and Dr. Amit Gupta, we were part of the curriculum committee. But unfortunately, the course has not started. And recently, the MGM Medical College, Navi Mumbai, they have been sanctioned to take 2 PG seats in MS in traumatology and surgery. And there is a need in the country. And I would request the Professor V.K. Paul and Professor Sunil Kumar to take up this issue and have more and more Department of Trauma Surgery and Acute Care Surgery in the country, so that we can have more acute care surgeons in the country. There is enough literature which supports that trauma surgeons should be doing both traumatic and non-traumatic emergency surgeries. This is the Bible of Trauma by Professor Kenneth Mattox, and who will be actually speaking in this conference on 5th of December at 6 p.m. in the evening. And I will request everybody to listen to him. And he said in his book that the trauma program should supply the necessary volume of variety of trauma, critical care, and emergency general surgery to assure adequate training. So the trauma surgeon should be doing 50% traumatic and 50% non-traumatic emergency surgeries as well. So there is a need to establish the Department of Trauma and Acute Care Surgery in every medical college in the country. This is my earnest request to all the dignitaries on the dais, and we should have more and more postgraduate courses in this specialty. Thank you very much for your patient listening.
Thank you.
Release kara do, 2 minutes.
I would actually request him to enlighten us, sir, with with a few words, so that we can move forward and we could actually have your support behind us in the cause of trauma care in India, sir.
Thank you very much. I think it will be now apt to release the senior, the e-proceeding. So let me do that pleasure first, and then we will proceed further.
Yes, sir.
Thank you so much, sir.
Yeah. Hope you can see it. I'm pleased to inaugurate the release of e-proceedings. I guess this is the...
Sir, you can run through.
This is the lovely hall in which we are supposed to be floating around in these times. And this is lovely format, extensive coverage of new literature, new studies, and wonderful people who are leading this whole initiative. Thanks for the leadership. Very nicely done. I think it's remarkable. It's remarkable.
Thank you very much, sir.
Thank you so much.
Thank you very much, sir.
Thank you so much.
Yeah. You can stop sharing, sir.
We'll unshare it. Okay. Good afternoon. Respected Professor M.C. Mishra, my very dear mentor, colleague, friend, teacher, I'm honored to be here, sir. Dr. Sunil Kumar, our DGHS, Dr. Vinod Jain, President ISTAC UP, Dr. Subodh Kumar, Vice President, Amit Gupta ji, our Secretary, and Dr. Sushma Sagar, Scientific Chair of the meeting, and distinguished colleagues who are present around this video conference at the inaugural session of the ISTAC. It's an opportunity for me because being a pediatrician from the medicine background, we have many things to learn in the sphere of surgery and surgical disciplines. It's always fascinating. But more importantly, it is an opportunity for me because we are dealing with, we all are dealing with the increasing morbidity, the burden, and the mortality due to trauma-related issues in our country. Accidents, trauma. This is a very, very major area of concern, major burden of disease, and we still have a very long way to address it. And we must endeavor that we accelerate our systems, strengthen the systems in such a way that India is known in the world as a successful implementer of trauma prevention and trauma mitigation services. I'm so happy that you challenged us in a very systematic way, Subodh, by putting out specific issues for our feedback. And I'll be very happy to do that. But before that, let me congratulate the organization for your stellar work. The super specialty organizations have generally a smaller base, niche participation, but they play a very important role at the cutting edge of development of the discipline, the science and the art and the ethics of the discipline. And I did that way back in neonatology, so I can relate to areas such as your area, where you're pushing the frontier in a systematic way, building on what leaders like Dr. Mishra have started and shown the light, and we're taking the light forward. So I congratulate you for your spirited work, for the academic movement that you have created, as well as the policy movement that you are championing. And I value, and I'm very proud. I value your work, and I'm very proud of your achievements. Let me go in the area of some concerns that you have expressed. Firstly, let me mention that our team as a board of governors has taken a very important decision, which you may be aware of, that all medical colleges will have an emergency medicine department by the year 2022. That decision was taken about a year ago. It's an implementation. So all medical colleges, old and new, will have an emergency medicine department. So first, I'd like you to think about how that can be used as a big and important and large pervasive platform in the country for the objectives of preventing long-term morbidity, preventing mortality due to trauma and accident in our country. How can we bridge the two goals, your objectives and your sentiments, with this opportunity? Because that opportunity is right there. And I guess it is a starting point for more sophisticated care. So that is one area where we should work together, and we should work with other partners for creating the entry point for the care of cases of trauma and of acute care surgery. Also, we are looking at, not COVID actually had dislocated many things. And one of the areas which it has sort of dislocated or delayed is our endeavor to have a national accident and trauma, shall we say, network or a grid throughout the country, building on the experiences of the past to which you referred about the medical colleges having trauma centers, but also more extensive networks of care provided in some states in particular. And I'm particularly proud of the work that has been done in Tamil Nadu, where there is a network of emergency services, ambulance services, and then patients are directed in a systematic way using GPS location. And I believe that is serving the cause of both trauma and broadly also accidents. And we've been looking at this model and looking at other models, such as the one operating in Andhra Pradesh in particular, to see how a universal model for India can be created and then can be scaled up. We are also very keenly looking at how to make the care of such patients free and not out of pocket. Fortunately, there is a provision for road safety fund in the new law, And we have that resource available. And that could be used to ensure that the people who have trauma, who have accidents, their care, particularly trauma, particularly road traffic accidents, their care can be without any out-of-pocket expense, assured care for the first, let's say, 48 to 72 hours. So making it universal for everybody. That assured care at both government institutions as well as private institutions. That's one of the other areas of work that NHA and NITI, we are working together in this area. Dr. Mishra mentioned about skills-based training and ATLS as an essential learning opportunity. I'd be happy to state that this is something we have floated to be implemented in internship, because with the need coming in, internship will become a renewed and resurgent opportunity, which has been previously lost to the cause of coaching for the postgraduate programs. But we are looking at NEET, where the theory, so-called theory, is done before internship and practical is taken after internship. And therefore, people would immerse themselves much better during the internship. But also, there could be other opportunities in the competency-based curriculum where we should make this mandatory. And this work we have started, I'm sure, Dr. Sharma and his team in NMC would take it forward. And likewise, Dr. Sharma, as a legacy from us, we have been working to create credit system for ensuring continuous education for postgraduates, for doctors in general. He's actually very keen to even consider recertification for all doctors. So this is something very close, and some work that we did, we have passed it on to him. I like to also mention the development of telemedicine guidelines, which have now become available, because of which the uptake of telemedicine in all the areas has become a true possibilities. And in COVID time, it has gone phenomenally high in terms of millions and millions of consultations through teleeducation, through teleconsultation, and also a huge fillip for telemedicine. I would like the team to consider that even beyond COVID-19, opportunities for tele-learning and teleconsults wherever applicable. Let's say even in the post-discharge scenario, why should patients have to come if we can just visualize them on a video? So look at those paradigms to be used for future. And this could be the time where you can test them and validate them in a systematic way and say, look, this is okay. Up to this point, the decisions can be done through teleconsultation. So I think that opportunity, I'm right now counting the opportunities where your objectives, the objectives for which you stand, can be aligned to activities and to the missions that are emanating from other areas. So I think truly telemedicine is an opportunity. And I hope even now, through the acute care paradigm that you represent, you are mentoring surgeons, other surgeons in small and big places through e-consultation, e-ICU, e-care, e-trauma. Kindly create this paradigm, because this will never go out of fashion. This will always be needed. The sophisticated surgeons of a high level would be a scarcity in any developed country as well, leave alone our country. So I think the hint to you is think about certain things that can be sustained, where you as the super specialist surgeons are helping others to undertake procedures that can be facilitated through teleconsult. So think about what are those areas where it can be done. Think about how these things can be taught, and never forget the nursing component. That's my other request, that I would like to see in your organization a very major paradigm on nursing. And I can relate to it again because in neonatology, for the newborn movement in this country, we took the nursing along, and therefore I like to see nursing leadership sitting a part of your board, nursing aspects being tackled as a thematic area, every conference, every annual conference. And I'm sure you will make a huge difference to the actual care as we go along. It's a specialty by itself. It's a skill by itself. We may or may not elevate into a formal specialty, but I think training nurses in this area would be very important. You alluded to something which was very specific, and I like to now talk about that. If we have to address mortality and good to ensure good outcomes of patients of trauma, we must look at it as a tiered affair, which I know you are aware of that. But the point I'm making is, I like to visualize what are the layers of surgery to be implemented at various levels and where specialties give way to super specialties. I'm right now a bit, I know that it is different for AIMS where frontiers have to be pushed. We have to nurture super specialties and within super specialties, further specialty, because that is India's presence on the scientific scene. India has to be seen as a science leader as we are doing it in COVID vaccination, for example. We must be pushing the frontier, but at the same time, what I'm now seeing is specialties which are bridging with each other. Some in the super specialty domains, as you very rightly showed, FNB and the MCH courses, and then we have something which is in the space of general surgery. What I'm wondering is how this is to be aligned to overarching needs related to the various levels of care. Help me understand that offline at some point. Where do you fit in? And where do you link it to the opportunities that I am visualizing right now and more that may be coming? How do we do that? For example, if an emergency medicine department has to be a reality in the next 2 years, 4 years, let's say, can there be acute care surgery as a precondition to, as one of the qualifications to become emergency medicine faculty? That pathway can be readily opened if there is a supply available, provided that there is a supply chain. Would you like to position general surgeons in that direction? And could that be the model on which we work? Because we do need emergency medicine departments as an entry. We do need then trauma from where it branches into trauma side, I guess, and then other players and other specialists come in. So I think what would be useful would be to understand how, I know we have debated this at AIIMS, and Dr. Mishra, you remember I pitched for super specialization because it was AIIMS, but I like to understand better that in the general paradigm of an MC system where we can influence and we can work together, where do you see the position of post-MBBS level acute care surgeon, if there is any, or is it to be a specialty? Now remember, when it is a specialty, then we are not available on scale. We must appreciate that the super specialists are not expected to be available in every district, every town. They are not. They're supposed to be in tertiary care centers. So if the burden is such that it is all over, then it has to be brought down to a level of specialty at best. And I like to see how different courses you would like to align according to these structures that are available, because that will help us to understand. And then we all put our weight behind it, whether this is to be done through the MCI system or it is to be done through the national board system or to be done for fellowship systems or certificates and so on. And also then how do we align it with other people that are available? So my request would be, think about overall structure of the services that is emerging, which we can try to foresee, and we can help you in doing so. And then say where you would like to have a surgeon whom you pass on the critical knowledge and they handle it. And the super specialists stand behind at the cusp of frontiers of science, frontiers of art, and frontiers of technology and surgical techniques. So I like to see that separation. And that, of course, is a guidance that your organization can provide. And then I think we can surely work together. And this will also help us, create a paradigm where the accident and trauma, critical care, how this is bridging together and how we can have a generic approach up to a level, and then it branches into more specialized care. Because I think we better tackle this, because sooner we sort it out, better it is for us to communicate to people who have to be then convinced for taking it forward. Otherwise, I saw something that you saw about one course which came up in 2010. Why it has not taken up? So we created a supply, but there was no demand. So I think we must be wary of the fact that there should be a demand on the other side, and it should serve the larger purpose. And yet, if specialties are needed to be on the frontier, global frontiers, national frontier, they have to happen. And for them, the demand comes in future. So we look at future and emerging demand as one paradigm, current and existing demand and the need and the urgency in the other. And we create a pathway, a seamless pathway, which we can convince people, we'll have people on board, and I think that will be the way forward for us to do it. Having said that, no matter how we go about doing it, I seek suggestions from you how to multiply expertise. We have the National Board of Education System, which is flexible, which comes largely from the private sector, and we have a huge private sector which is waiting to be harnessed optimally. How much can we rely on that, and how do we create that system? This is very important. It won't happen automatically. How do we create opportunities on that side that a significant number of such hospitals take up that kind of somebody has to shoulder the training program. Otherwise, we'll remain very rare. Likewise, how can we push the same on the side of medical colleges and the NMC system that you have been referring to? But certainly, as it is again true for emerging areas of expertise nationally and globally, we will have to tackle these issues. We must take people along and to convince anybody for the need of expanding the expertise in and capacity in trauma. It doesn't need convincing, but I think what we need to do is to make sure that the services that we create, we are able to create the right teams. We are able to ensure that there is financing and resources are made available, and we make a success of the opportunity. And here I like to make my last point, and that is I like your organization to study the trauma services that the government had put in place. This level, how have we done? Can we improve? How do we improve? What are the gaps that we need to address in the next phase? Because I know that we have success, but we don't have full success. We would like to see what is the best. So you keep that learning also in mind when we are proposing new ways of doing it. But in the end, I salute you for your work. I salute you all for pushing the frontier of a very sophisticated, intense, unique, science-driven, art, primed specialty that you are all taking on your shoulders. And I'm proud of the leadership that Dr. Mishra has provided. And I'm alert to the need for all of us, this great need for all of us to support. And I assure you, I look forward to working with you and kindly guide in the opportunities. And we have DGHS with deep interest in this area. So together, we'll try to significantly take your objectives forward in the service of the nation. Thank you so much. Good day.
Thank you so much, sir. Spoken like a true leader and mentor, and I think sort of clarified many things. We would also like to continue this association and meet you regarding our thoughts and many of the thoughts you had put forward, like the already rule of establishment of emergency medicine departments, how to leverage that, how to dovetail our acute care surgery into that, the telemedicine and trauma, how rural centers can benefit from even real-time telemedicine, even if they are resuscitating a patient in a smaller hospital and don't know. We've already worked on that a bit, but we'll definitely need your help. Nursing empowerment, and I think you would have seen in the trauma center when you had come earlier that we have empowered our nurses to the extent that this is the 10th annual conference, and each and every conference has a nursing session. Even right now, there are parallel nursing sessions in the second hall, Hall B, and also nursing papers. I mean research, which we have taken a clue from neonatology, and we know that until unless you specialize the nurses also to do majority of the work which our junior residents and senior residents do, the senior residents and junior residents could not be engaged in good scientific research, and I think our nurses are helping out in that also. But yes, we've taken a lot of clues from your address. Thank you, sir. Thank you once again for blessing us and joining us in this inaugural session of the 10th Annual Conference of ISTAC. And to carry forward the inaugural session, I would now request our keynote speaker, Professor Vinod Jain. Professor Vinod Jain is a distinguished and senior professor of surgery at the King George's Medical University. He is also leading the ATLS championship in the huge state of Uttar Pradesh, and he is the president of the UP chapter. Last year, we had the UP chapter formed of the Indian Society for Trauma and Acute Care. Professor Vinod Jain, sir. So could we have your presentation, please?
Sir, you are not audible. So can we move to the oration first?
So you're not audible.
In the interest of time.
We can't hear. Dr. Sushma,
So I think because the inaugural ceremony has to end within an hour. I'm sorry that probably there is some technical problem with Professor Vinod Jain. So he will join us later. But it is my proud privilege right now to introduce the ISTAC orator of the day, Professor Dr. Sunil Kumar, a very dear mentor and teacher and associate who has such a passion for trauma and acute care and the cause of trauma and acute care in India. This is the second ISTAC oration, and overwhelmingly the society executive decided that this year's oration would be given to Professor Dr. Sunil Kumar, who is also one of our esteemed members. I'll just read out the citation and the introduction of the orator. After completing his MBBS and MS in General Surgery from AIIMS, New Delhi, he joined as the assistant professor of surgery at UCMS and GTB Hospital in '88. He is a renowned teacher and a surgeon par excellence. Loved by students and colleagues alike, he became the director professor of surgery at the GTB UCMS in 2010. He was appointed as the head of the department in 2014. Exemplary clinician and administrator, and we've known it ourselves. He has published many research papers, and he has been associated with ATLS right from the inception of the Advanced Trauma Life Support course. He has been appointed as the MS, and of late in August 2020, we had the privilege that he was elevated to the position of Director General Health Services, Ministry of Health and Family, USA, Government of India. Professor Sunil Kumar, sir.
All right. Thank you, Dr. Amit. Am I audible?
Sir.
Right. I'll start sharing my screen with you. The screen is visible?
Sir.
Great. Great. So I compliment you for doing such a wonderful job of organizing ISTEC online, where we are meeting once again with our colleagues, with our teachers, with our students, with our future teachers as well, and trying to find out what we can do for our beloved country. I definitely would like to put a word of warm regard and respect, and as attached with that, a huge thanks for the wisdom, for the stellar words that Professor Paul, the health member of Niti Aayog, had just given us, had spoken a few minutes ago. My compliments, my best regard to Professor M.C. Mishra, the President, who it appears is traveling our meeting. Dr. Amit, the Secretary Stack, Dr. Subodh, Dr. Sushma, many other colleagues, Dr. V.K. Jain. My compliments to all of you and regards to all of you. I will begin with the oration. Fortunately or coincidentally, Dr. Paul also suggested that trauma care nursing has to be brought forward in a big way. And I have always felt that nurses carry or shoulder a huge burden of patient care in our hospitals. They not only work in operation theaters, but they also work in OPDs, various clinics. And I feel that nurses have not been given their kind of share of responsibilities, of making judgments, of administering treatment, whether it is a simple form of treatment or and then monitoring. The kind of responsibilities that India could have given to them vis-a-vis the West, we have not done that. And my feeling is that this huge batch of healthcare professionals is hugely underutilized. And therefore, I chose this subject of nursing cadre and trauma care, the current status and the future directions. So that's the reason why I chose this. Now, how do I go to the next one now?
So just tap the board, or you can go on the left. Yeah.
So it will not be far-fetched if I remind how the trauma, the beginning of the trauma nursing care was initiated by Florence Nightingale in Crimean War in 1854. So it's a long work in 1898 by picture depicts the work assigned to the nurse right in the middle of the ongoing war. And we were joined, we had the nursing cadre working in World War I as well as in II. Full credit to these strong ladies working in the field. So a credit goes to them for creating a history which we can follow now. The shock center in the United States is credited for beginning the trauma nursing courses formally. What is trauma nursing? As far as we are concerned, is a specialty area of nursing practice which includes the component of care of injured and those at the risk of injury. Pre-hospital care and would involve the triage, the stabilization, the support, and the rehabilitation and integration into the society. So that is the spectrum by which we are trying to find what they can, how and what they can contribute in terms of the trauma care. They play a pivotal role in assuming the quality trauma care services and the well-organized trauma centers. And it is the continuum of clinical care provided by them which makes their contribution valuable. They can attach invaluable expertise to the complex physical as well as emotional needs of the trauma patients as well as their families by virtue of their gelling with them, by virtue of the empathy with which they can work with their families as well as with the patient. And what needs to be taught is the critical care approach, and are already working in this direction, and so it's not a difficult area to match up or to notch up. Trauma nurse, which can be, they can play significantly administrative responsibilities. They can contribute in quality improvement, and they can also play valuable roles in trauma registries. So these are the 4 categories. In addition to this, I think it will not be an understatement if we say that they contribute significantly in terms of the response. Working they have also at par with the doctors and other cadres in terms of the computer knowledge, the software knowledge, and so they can contribute immensely in terms of the data compilation, also data analysis. So they can contribute significantly for research too. There is a strong evidence to support that the placement of specialist trauma nurses leads to a significant improvement in patient as well as health services outcome. So there is unrefutable, and therefore we should tap on that. It's essential to achieve the good results, and timely care is provided by a team comprising of doctors, mostly at the moment in India, but in Western countries, it is the nurses play an important part in the team that provides the acute trauma care as well as the trauma care in the wards, in the operation theaters, in the ICUs, as well as in the follow-up clinics and in the society. This is quite complex, and you can see that various countries have adopted the various roles given to the trauma to the nurses, nursing cadre, to care of the acutely injured. Others cannot follow the same. It is definitely emerging as a specialty, and specialty approach is required in order to give them due recognition, give them the due identification that they are playing a critical role in the management of the trauma. There are multiple training programs which are available for the trauma care for the nurses, which are fine-tuned, which are specially designed for the nurses. The nurses can play either a role as trauma nurse practitioner or emergency nurse practitioner, and they can address the patient's need at various levels, including the peripheral health centers. The quality manager's role can also be assigned to the trauma nurses quite easily, and they are able to discharge those roles in as far as the various studies are concerned. They have been convincingly show that they can play that role in a comfortable manner and in a quality manner. The nurses can be given a multidimensional role and responsibility. They can play a critical role. Assurance, the leadership, not to forget about the leadership in the ED, which I think the JPN model is following. We will come to that in a minute. And they can also provide invaluable administrative support and the research which I already have been prescribed, to which we can adhere to, while ensuring that we are able to generate the quality nursing cadres in their trauma care. So that can be these standards which are prescribed for equipment, maybe for training, for the care, for the inpatient care, for the critical care, or the building of the hospital, or the layout of the wards, etc., etc. These are quite well known now, and they are very much part of it. Outpatient care is not new to the nursing care. The greater assume that, and they are able to deliver. So they can be given in the follow-up clinic, in the various responsibilities of assessment. Patient assessment can be taught to them. It is a skill which can be easily transferred to the nursing cadre, and they can be of invaluable assistance to the doctors. They can save their time for making critical decisions. In the US, we all know that there are various specialty courses which are run for the nurses, and they can be a certified emergency nurse, flight registered nurse, pediatric emergency nurse. So all these options are available to us. Critical care nurse, which incidentally is also started in Delhi, I suppose, very soon. So this we have already seen. The future belongs to those. It is not. This is not a slide which is to be taught or shown. The future belongs to those who believe in changes, who believe in realizing their dreams, and the dreams can be wild. There's no doubt about it. What is the current status of trauma nurses care in India? As of now, a huge gap can be perceived in the role which has been assigned to them, in the performance of the nursing cadre in the trauma care. The gap is basically primarily the way we use them, primarily the way we train them, primarily the roles that are assigned to them, primarily how much dependence we show on them. And therefore, it becomes more of a habit, it becomes more of a character building, it becomes more of a assignment, it becomes more of a training that can be given to them. We cannot expect a nurse who plays multiple roles, who is transferred, who is not allowed to stick to one particular practice area, to become an expert in that area and to be able to teach, to be able to do a quality research, to be able to lead from the front. And therefore that becomes the most important thing, that how we use these cadre. Typically speaking, in the sub centers, the patient can either be given an immediate emergency care and be referred. And the same thing is true with the PHCs and the community health centers. And it will not be out of the context if I say that immediate emergency care in our circumstances is little doubtful. So the care actually begins, acute care actually begins from the community health centers, maybe in fact, I would say it actually begins from the district hospital levels. And that too, majority of the patients are immediately transferred by maybe making a MLC kind of a thing, maybe some kind of a fluid is started, and the rest of the things, collars are not applied, the oxygens are not given, the patients are not put on spine boards, the fractures are not stabilized, which continue to add to the adverse outcome when the patient reaches the untrue of the secondary care hospitals. True. It is only when the patient reaches a medical college or a tertiary care center that we start getting a comprehensive trauma care. Can we not give it? The question is this. The JPN Trauma Center model leads us from the front. The trauma nurse coordinator plays the role which is exemplary, connects the patient with the team leader, the emergency, the blood bank, the surgeon, and survival of the patient, or attempts to survive, to make the patient to the theater and have the best outcome possible. These are some of the daily responsibilities of trauma nurse coordinator at JPN Trauma Center, and we can straight away copy them. Maybe if we have great ideas of improving upon it, we can, but at least this model has been running for many, so we can straight away copy from that. And Professor Mishra has been exemplary in installing this system. Then it has been improved over a period of time by reviewing the status and adding the improvements in injections or in installments. And the result is that they are contributing immensely to the care of the injured patient. So I'm very sure that this can easily be duplicated. Therefore, I would say that steps in the improvement of trauma nursing care in India would begin with identifying the fact that, understanding the fact that they can be given a significant role. They can play a significant role. They will be able to give the continuum of care to the trauma care to the patient, right from the lowermost step in the ladder, that is the peripheral hospitals, to the tertiary care hospitals, and they can be trained accordingly. They can be they can make a separate cadre, and we can strengthen our framework by their presence, by giving them the advanced roles like research, the quality managers, the responsibility as the team leaders, the policy makers. Let's not forget about that. So national health policy has recognized some of these needs, and they have brought in the regulations and the quality management for the nurses education. The terms like nurses practitioner and public health nurses. We hear that specialized nursing training courses and the curriculum are being designed, for example, for the neuro care the trauma care, the vascular care, and each nursing staff, the nursing cadre can have, they can undergo these kind of specialized training in order to contribute to each one of these, or they can have a broad-based, like acute care and critical care. The policy recognizes the fact that district levels and those who are already established, they have been running well, they can upgrade to provide the BSc nursing uh, courses in the larger district areas. This will tell you now how a nurse can be, is not in any way less competent than our doctors. You see, they are effective and prompt communicators as equal to the doctors. They can be taught assessment of the patients. The first aid can be administered by these patients, and the first aid, when I say, means giving oxygen, stabilizing the patients by giving the IV fluids, maybe putting a collar. These are the skills which can be easily taught to them, which can easily be transferred to them. It's not a big difficulty, and they can be taught how to recognize the situations where all this will be needed. The treatment by priority, the patient needs. During the transport, they can accompany the patient with equal success vis-a-vis the doctor, and the doctors can be spared to work in the EDs. Community health education. In fact, it is 4+ here and 4+ here. I would say that 4+ should be here and 3+ should be here, because the nurses can play a vital role. They can play a big role if the doctors are playing these responsibilities: the initial record and registration, assistant in treatment plan, daily inventory, infection control program, etc., etc. All these responsibilities can also be easily transferred to our nursing cadre. The doctors and nurses can play an almost equal role in preparing the rehabilitation plan and executing them, take decisions in the change of plan, and then follow those change decisions, do periodic assessment. They can also be part of the periodic assessment. They communicate with the patient. In fact, they are more effective communicators with the families as well as the patients. They may be having more knowledge, the skills, but their knowledge and skill base can be expanded easily by means of training. So in our low resource setting and wellness centers and peripheral health centers, we require a basic trauma trained nurses. And in our advanced centers, secondary level onward, and tertiary care and the super specialties, maybe we can place the specialized nurses or specialized trained nurses, for example, critical care or the cardiac care or the pediatric care or the neuro care and trauma care and like that. So trauma nurses practitioner can play a vital role not only in the hospitals, but can also play a significant role deep down into the societies by means of easy penetration into the societies and mixing up with the families where they are known to play a significant role. The programs which can be which need a wider support and which need a wider implementation and wider planning in terms of the trauma nursing cadre utilization will be imparting them the ongoing basic life support training to all the nurses. We can have the trauma nursing cadres, trauma nursing coordinators in all the hospitals, just on the lines the JPN Trauma Center has done it. We can have Dr. Paul has just already mentioned that the emergency departments will be coming up in almost every medical college. In fact, I would say that it is not the emergency department. A teaching emergency department can be, can come up in a district hospital, which is now going to be a medical college, and upward in all the medical college. In however, emergency department, a functioning emergency department is a need in every hospital. They should no longer be called as accident and emergency departments. They should be called as emergency department. Now, whether they are teaching or non-teaching is a different matter altogether. Now, this is known that how we can empower them. There's nothing new in it. With this, I'm coming to the end of my oration. I would like to sum it up by saying that in give trauma care, what we need to do is recognize that they are valuable, they are invaluable. We need to empower them. We need to groom them by suitable training, by giving them more and more responsibilities, and allowing them to work in those particular areas, specialized areas, including working with the society at the peripheral level and in a highly specialized center, particularly in different areas like critical care, operation theater, ED, and like that. So the earlier we recognize this need and we start our journey, the better it will be, because the patients are first met by the nursing cadre in almost every hospital, in every unit. They are present in the larger number. They are more than the doctors, so they can easily be the first encounter or the first persons who meet the trauma patients and start the process of resuscitation immediately. So with these words, I think that my submission will be that we must begin on immediately. The earlier, the better. Thank you very much.
Thank you so much, sir. Thank you for a wonderful oration. And you have touched upon a very important topic, and trauma is a theme we all know. And bringing in this topic from your highly esteemed office means a lot to the a very important cadre of trauma care in India. Now, with this, we come to the end of this inaugural session, and I thank all the people who have been involved with the organizing and commissioning of this Trauma 2020 virtual. From the bottom of my heart, and along with my colleagues, Dr. Amit Gupta, Dr. Subodh Kumar, and Dr. Manish Singhal, I thank our chief guest of the day today, Professor V.K. Paul, who with his busy schedule has agreed upon and has given words of wisdom on the trauma teaching and acute care surgery model of India. I thank Professor Sunil Kumar for accepting the invitation for giving the oration on this virtual platform. There is a change. Our keynote address today has been shifted for tomorrow, and Professor Vinod Jain will be talking on the training in trauma, a service to nation, tomorrow from 3 to 4 in the ATLS trauma training program. So thank you, Professor Vinod Jain, and we would be listening to you tomorrow. I thank Professor Mishra, who's been always a mentor and a guide, and who has given us this idea to conduct this conference this year from a virtual platform. I thank all the international and the national speakers for agreeing upon to deliver their talks in the upcoming sessions. I thank all the delegates and the participants who have overwhelmingly participated and presented and their oral and poster presentations today and in the upcoming sessions. My co-faculty in the Division of Trauma Surgery and Critical Care, and all the residents who have participated in front and who are taking the clinical responsibility of clinical care in the division. All the office staff, Nitin, Brijesh, and Abhishek, Yogmaya, who have been hardly working for the conference. Mr. Prem for taking out the e-proceedings in less than 24 hours. And our virtual platform partner, Mr. Nimit Soni, Mr. Pratik, Mr. Shubhang, and their backend team. So thank you all. Thank you very much. And now we move on to the next scientific session of the program. Thank you so much.